Indigenous peoples and communities. Today's Lunch and Learn will discuss the important issue, as I said earlier, of assessing senior care in English. And I'm really pleased to be here because I also am the main caregiver of two parents, 193 and 194, and I've had personal experience in terms of accessing care for them. In fact, just to give you a little a personal note, it took me 3 years to open a file with the CLSC because they were not hospitalized, they were living in their own home, which is what we hope most people can continue to do at that stage in their life. So I'm looking forward to hearing what the research shows, but from personal experience, it has been a difficult road for me and my parents trying to have access. And one of the main barriers has been language, obviously. My parents are of Greek origin, although they speak English. I'm the one who mainly translates for them in terms of the system, which is geared more and more towards having assistance from Francophone participants, and there are very little services in English. So I'm looking forward to what the research is showing. Ongoing healthcare crises have disproportionately affected members of our English-speaking community who are weaker access to necessary health services in our language. Our report highlights the unique challenges faced by English-speaking seniors in accessing essential health services, including basic doctor's appointments and long-term care. Today, we will present the results of a study by the QCGN's Access to Justice in English in Quebec team. The survey report, which has been shared by with government healthcare stakeholders, examines English seniors' access to health services in Quebec's Soutien à l'autonomie des personnes âgées programme. I would like to take this opportunity to remind you that only our presenter is permitted to speak during the presentation. All other participants will be muted. Please note that there will be a Q&A session following the presentation, and we do encourage you to submit your questions in the chat, and we will do our best to answer all the questions, although we may not necessarily get to all of them, but we encourage you to identify yourself. Time permitting, as I said earlier, we hope to get to all the questions. Let me begin, and it is my honor to begin by introducing Walter Duzara, the president of Seniors Action Quebec, which has been on the forefront of this access to healthcare for our English-speaking seniors. A former member of the QCGN board of directors, Walter spent more than 2 decades in education. After teaching mathematics and physics at the high school and CEGEP levels, he was the principal adult education centers and director general of a school board. He also worked for the Ministry of Education as a curriculum specialist, department manager, and senior management advisor for more than 20 years. Walter served on the board and executive committee of the Community Economic Development and Employability Corporation, the CEDEC, sat on the executive committee of the QCGN for 6 years, during which time he chaired our priority setting steering committee. Walter, over to you.
Thank you very much. Hello, everyone. Just a few words. Seniors Action Quebec is pleased to participate in this discussion of the QCGN Access to Justice in English report entitled Access to Senior Care in English in Quebec. SAQ was a contributor to this report and assisted the Access to Justice team in the preparation of the survey questions. As a provincial organization, SAQ strives with its partners to identify, advance, and address the needs of English-speaking seniors throughout Quebec. This report provides our community and government agencies at all levels with evidence that identifies many of the challenges English-speaking seniors confront when accessing healthcare services, particularly home care services. I will not speak to the findings of this report. We will hear from the QCGN team shortly. However, as president of Seniors Action Quebec, it is my duty to speak to the essential nature of research like this. Most Quebec citizens experience little difficulty in receiving information about available healthcare services. Most Quebec citizens can express their needs to staff within the various institutions providing health services. Most Quebec citizens feel at ease and welcome in their various institutions, but not all. Language is often the greatest barrier to access and the greatest source of distress for English-speaking Quebecers in crisis. English-speaking seniors represent 15.5% of the English-speaking population, a number which has grown since the last census and will likely continue to do so. This language barrier is particularly troubling for them since almost 50% of English-speaking seniors over 65 are unilingual English. The pandemic exposed many cracks in senior care services, which had long been hidden from public view. It exposed the fact that gaps and shortcomings in care services for seniors exist within both public and private care facilities. It also exposed the general lack of knowledge and understanding of available services for seniors and for caregivers within the community and within the institutions themselves. The government of Quebec must continue to make senior care a priority. To that end, we are encouraged by announcements in the recent budget, but are wary and will closely monitor the efforts that will be proposed to ensure that English-speaking seniors receive the services to which they are entitled as Quebec citizens. However, this is not enough. It is our view that healthcare is a human right. In alignment with the principles affirmed in the 1946 Constitution of the World Health Organization, it is our view that governments at the federal and provincial levels must legislate positive measures to ensure that healthcare is equally available to all citizens as their human right. We are disheartened by many of the findings in this report, but it is this kind of evidence that is needed if we hope to enact change. This evidence serves as a catalyst in our collective work with policymakers and government officials. It was a privilege and pleasure to work with colleagues on the development and delivery of this project. Thank you.
Thank you, Walter. Now it is my pleasure to welcome Jerry Sklavounos, or Maître Jerry Sklavounos, and who has been with the QCGN Senior Advisor Legal Affairs since June of 2021. Jerry has a Bachelor of Civil Law and Common Law from McGill University. In 2007, he was elected to the National Assembly of Quebec, where he served 4 consecutive terms. During that time, he served as Deputy House Leader, Parliamentary Assistant to the Minister of Health, and Chair of the National Assembly's Health and Social Services Committee. Jerry will provide a summary of the report outlining some of the challenges our seniors face in accessing the care they need. He will conclude the report's recommendations of how healthcare policies and programs can be improved to provide proper access to healthcare for our seniors in their own language. And again, if you have any questions during the presentations, you can put those questions in the chat room and we will do our best to be able to answer those questions. Either Jerry, Walter will be able to answer your questions. So over to you, Jerry.
Thank you very much, Eleni. It's a pleasure to be here today with all of you. Thank you for taking time on your lunch hours to be with us. This, this project is entitled Accessing Senior Care in Quebec. And we chose this issue because there was work done previously by QCGN and polling done, which made this a priority. I'll explain a little bit about the project and how we work. If we can have the next slide, please. So the QCGN Access to Justice project identifies and researches areas where the English-speaking community are experiencing difficulty accessing their rights, with a strong focus on community access to public services. So the fact that we're the Access to Justice team does not mean that we look at courts and tribunals uniquely. we look at rights more largely, and therefore, as Walter mentioned in his comments, these rights include accessing public services, and health and social services are amongst the most fundamental consistently when people are polled about what their expectations are from their government. So we leverage information. This is not about lawsuits. It's not about preparing litigation. It's about extracting information, information from not only publicly accessible information, but digging through study, inquiry, interviews, and investigation to get the kind of data that we can use to further the debate, push the conversation, and advocate. Next slide, please. So access to healthcare services for seniors in Quebec is done through Quebec's SAPA program, Soutien à l'autonomie des personnes âgées. So that's what we looked at to a large extent. This report was released on February 28th of 2023. Next issue. Next slide, please. Why this issue was chosen, as I mentioned before, there was polling done by our group in September of 2021. A population survey of 1,601 English-speaking Quebecers, conducted then by Chorus Consulting Group, identified that hospitals and CLSC care were amongst the most widely accessed provincial government services by English-speaking Quebecers. More than one in three English-speaking Quebecers at that time who were interviewed said they had accessed services in the past 2 years and had found it difficult to do so in English. We can't forget that during that period of time, senior care was under close scrutiny. As Walter mentioned, we were coming off on the tail end of a pandemic, which had exposed different flaws, difficulties, gaps in services. And I don't want to remind everybody that many of these flaws and gaps led to some dramatic consequences, including deaths, and there were coroner's reports and other investigations and a lot of media on it. We thought it was a timely issue, and we wanted to shed further light on the situation. Next slide, please. So how we do what we do. Our main lines of inquiry in our methodology are a study of the relevant policy and legal framework. We do that as part of the team. We also solicit an external legal opinion. And on this particular project, we worked along with Ménard Martin Avocat. You may know them, you may not know them, but they're one of the premier law firms that deals in class action cases relating to health and social services in Quebec. We also do a deep dive into the internal organization and administration of services, the organograms, who does what, where does the buck stop, and how are services organized. Then we look at the navigation of English-speaking seniors. In this particular case, we've done other reports on other issues, but in all the reports, we basically place ourselves in the position of the citizen who's attempting to access these services. And it's the best way we found to be able to pinpoint any friction points, any gaps, any problems along the way. So we did it in this case. And we also collected firsthand experience through qualitative and quantitative research. Next slide, please. So the primary data that we used in order to formulate our findings, one was a series of 16 qualitative interviews that were conducted by the EDGEC project team of community-based organizations, users committees, and other organizations across various regions of Quebec. And these were organizations and groups that had particular knowledge about the provision of seniors, of access services to seniors and their families. And we also did a quantitative and qualitative survey of English-speaking Quebecers, including 633 seniors that were age 60 and over, and 290 caregivers, because we can never forget the caregivers. And Eleni spoke about this in her remarks. So we interviewed 290 caregivers who are caregivers to a senior age 60 and over. Léger Marketing, we've been working consistently with Léger Marketing in our project, conducted this survey between November 29th, 2022 and January 17th, 2023. Next slide, please. We uncovered certain systemic barriers in English-speaking for English-speaking seniors accessing services in CLSC's long-term care facilities and other healthcare institutions, and we formulated 13 substantive recommendations. Next slide, please. Just to start on the legal foundations, this is not about the law, but everything begins with the law when we're discussing rights. So just very quickly, Section 10 of the Quebec Charter of Human Rights and Freedoms. That's not the Charter of the French language. That's the Charter of Human Rights and Freedoms. It's the equality provision. And believe it or not, language is one of the prohibited grounds of discrimination in Quebec by virtue of Quebec's own human rights and freedoms legislation. Section 15 of the Act Respecting Health and Social Services is the provision in the law that entitles English-speaking persons the right to receive healthcare services in English in Quebec. Of course, there's a catch where the human, material, and financial resources are available. And of course, the Charter of the French language, which plays a role in how designated services and institutions are those that are particularly geared and have population mass and are particularly geared towards the English-speaking community. So they have a plate of services that's more developed in English than other institutions. There are indicated healthcare institutions. These are institutions that have some services in English, but not all of their services in English. And Bill 96, of course, played into this situation because Bill 96 came in, and you'll remember there were provisions relating to recruitment in terms of human resources. And fundamentally, what Bill 96 did to Section 46 of the Charter of the French language is basically put the squeeze and saying that if you recruit someone who you're asking to speak a language other than French, i.e. English, you've got to justify that. You've got to justify that by the needs, and you've got to justify that by the position, and you can't have that there just to have it there. So this has placed extraordinary pressure where institutions have to justify why they're hiring bilingual staff or staff that speaks more than one language. And that's been a downward pressure for the institution serving English-speaking community. There are also some other policies. They're not up on the slide, but the health department's policy on outsourced services. We determined that sometimes outsourcing services, and it's going to become increasingly prevalent now. You've all heard about Santé Québec. You've all heard about the recent reform, the next reform to our healthcare system, with increasing resort to outsourcing. The danger with that is that the obligations and the responsibilities regarding language and provision of services sometimes fall off in the process to the outsourced party. So that's something we also identified, and we want to mention it at this point. And also in theory, there's complaints mechanisms. Next slide, please. There are complaint mechanisms whereby if you're in a situation, you can complain to the complaints commissioner, a particular institution. Eventually, complaints can go up to the ombudsman, la protectrice, le protecteur du citoyen, as we call them in French. The reality of the matter is, our research found that more often than not, and this is not just English-speaking seniors, seniors and people in that situation are very reluctant to make a complaint for fear of reprisals, for fear of rocking the boat, for fear of creating problems. You're in a vulnerable situation where you're in the healthcare system. You need help. You want to maintain the best possible relations with people providing the care, and a complaint may not be the way to do that. A lot of people decide not to take this mechanism, and I'm probably going to talk about it a little bit later when I have time. The problem when there are not complaints, when there should be complaints, is that we don't develop files, we don't develop data, we don't develop a critical mass of complaints to be able to push and advocate for change. So this is a little bit of a problem. While I understand why a citizen would be reluctant, it does create a problem for advocates. The larger number of complaints we have, the more data we can push for data to be collected, the more we can shine the light on issues, the more we can push for change. Next slide, please. Next slide, please. So fundamentally, there Eleni spoke a little bit about this as well. This is the typical way for a citizen who's autonomous, a senior that's autonomous at that particular time, maybe living at home, beginning to feel that they're losing autonomy. How do they get into the system? So Eleni was mentioning this, finding local CLSC access, the access point, via telephone, via other forms, opening the file with a CLSC worker, caseworker, social worker to build the senior's profile. There's eventually physical and psychological examination to determine the needs. And then there's an assessment of the scope of services that could be provided. This is for the senior living at home. They're in some kind of, they're beginning to feel a decline in autonomy. This is how they would go about it. That being said, and you had an eloquent testimonial from Eleni, getting an appointment, getting on the list, getting this started can be very long and very difficult. They're very difficult. And even for something as basic as this, if the region you are doesn't have bilingual staff, personnel, problems in communication could lead to disastrous results. And if we're speaking about someone who speaks a third language, well, then they require help. They require accompaniment. They may have someone to help them. They may not. This further complicates the process, not only at the beginning, but during the process. Because when we're conducting a physical and psychological evaluation, you need to make sure you understand the question. And we need to make sure that the provider who's taking down the notes is really understanding what's being said. And sometimes subtleties get lost. And that could lead to results that are less than desirable. Next slide, please. We jump to the navigation path for a hospitalized senior. It's a little bit more, it's a little bit easier because you're in the system. The senior is hospitalized, staff contact the access point, they coordinate. There's already reports in the hospital. We have a very good idea of the physical situation. Sometimes there's temporary movement to a living facility, which wouldn't be the final living facility for the person or the final destination. And eventually a place is found. Attempts are made to keep people closer to family, to their natural environment where they lived before, in order to maintain some kind of familiarity, which we know is important for seniors who have declining autonomy and capacity. Of course, between these two are the senior who's going from autonomy, receiving some care at home, into the CHSLD or into the hospital. It's a slight variation, but these are the two main navigation paths with their challenges along the way as discussed. Next slide, please. So we dug into this, and we dug into what was available online, how someone would attempt to access services. Interesting point, of the 22 web pages listing contact information for CLSC access points in each of the 22 CIUS, we found that only 3 were available in English. That's 3 on 22. We also found that in numerous cases, staff and healthcare providers, depending also on the neighborhood where the region, did not have a sufficient level of English to conduct the intake, conduct the evaluation, discuss, explain options. And this, of course, starts to create a lack of confidence. 7 in 10 seniors approximately in our study were receiving home care services in French when they would have preferred those services to be given to them in English. And about a quarter of the seniors, 24%, and caregivers, 27%, mentioned that this happens frequently. So they request care in English or services in English because their communication is easier, and they end up getting services in French, which create a problem. And that's where the last point here on this slide comes in. This has an enormous effect on confidence and on exchange of information and on facilitating the transition for seniors. Because we saw in our some other numbers, among the 43% of English-speaking seniors and 14% of caregivers who said they are not likely to request services in the next 5 years, 11% of seniors and 7% of caregivers said they're not doing so because there are no available services in English nearby. So the fact that those who are attempting to get services in English are getting services in French, this is a little bit, has a snowball effect. When you feel you're not going to get services in French, in English, you become reluctant to go towards the system and to request the services. You kind of self-censor yourself. And this is very dangerous because what happens is that particular time where vulnerability is present, the senior may fall through the cracks. Next slide, please. So Eleni was mentioning and others mentioned, and caregivers are an important part. And while the caregivers that we have found are doing an extraordinary job, are being personally exhausted, because often you have caregivers who are in the middle, who either have young children or other children, their jobs, parents to deal with at the same time. So, and you've heard about this. You've certainly heard about the fact that many caregivers are suffering from exhaustion because of the work they take on in order to help their parents or someone else in the family. But not all seniors have this. And the problem with that is the seniors prefer not to access services, risking social isolation. And the idea that when they get there, their first contact might not be comfortable in a language that they can understand creates, exacerbates the scarcity of services. So next slide, please. So the population experience went deep into caregivers. Only half, 56% of English-speaking caregivers felt comfortable navigating the healthcare system in French on behalf of the senior they were caring for. So the problem was that even the caregiver was having difficulty accessing. It gets complicated, it gets technical, and it rises to over 66% of caregivers to a senior that's already receiving home care services. So even when they're in the system, caregivers say it's difficult to navigate a system when you're not doing it in your language that you understand and in which you can communicate the best. There's obviously a rising demand. I don't need to say anything about that. You're all familiar with the statistics. There's a lack of confidence that's created by these situations. And there was one particular stat that I remember, not a stat, but a testimonial that came from one of the organizations serving the Black community that had basically many seniors who were attempting to access CLSC home care services ended up pulling out of the program and ceasing services because the communication was falling through. And this dealt to a lack of confidence, created a lack of confidence to the point where the seniors preferred to refuse the services, especially when someone's coming to your home where you feel safe. If there's communication problem, if there's not that building of confidence, obviously many seniors prefer to refuse rather than continue on. And we saw that there. We can move on. So there's an extraordinary lack of information available in English. I talked about the websites. They're not the only ones. There is a form that exists outlining services for seniors. It's called the Program and Services for Seniors booklet, published by the government of Quebec. It's kind of like a Bible for what's available and how to go about. Unfortunately, when we looked into it, when we looked at system knowledge, only 3% of seniors and 8% of caregivers had seen or read the Programs and Services for Seniors booklet. So it's wonderful to have this. The problem is it's not getting out there. It's not available. And I know when we were brainstorming with the team, we said, all the drugstores in the world should have these. So these should be at every point where a senior is likely to go. These should be available. Unfortunately, they're not. And lack of interpreters and English-speaking care personnel. We spoke about already the recruitment issues, the squeezing on the recruitment, which is a result of Bill 96. And also, MSS, the health department has a policy of providing interpreters where necessary in health situations. What we found, though, is in their interpretation of that policy of the health department, they tended to interpret it as if it meant interpretation for someone who speaks a third language. So you're likely to get interpretation and translation services if you speak Bangla, if you speak Punjabi, if you speak another language. But if you speak English, the administrators of the healthcare system, in our experience in many cases, were interpreting this as being a situation which didn't call for translation services. They were interpreting that as a situation that had to be dealt with the existing resources without calling upon translation services. So we were shocked. We were surprised when we found that, and that took some digging because some of the people were reluctant to speak openly about certain things, such as that. But it did come out, and it's very important. Next slide, please. So I've mentioned before a little bit about the disparities in availability and reluctance to seek care when you don't have the confidence that the care is going to come in the language that you best understand and that you can best communicate in. I spoke a little bit about cultural competency and the fact that if the confidence is not there, especially with certain minorities, racialized groups, we felt that accentuated. Communities that speak a third language but have a tendency to access public services in Quebec in English. So they're the adds-on to what Walter was speaking about as the native English speakers. They're the people such as Eleni's parents, such as my parents, such as others, who speak another language, yet when they're accessing services in Quebec and they have to choose, they will choose English because they're more comfortable in English. French is a step too far for them. They don't want to make mistakes. That's when they're dealing with all kinds of public services. We've done other studies as part of our team, and we see that when speaking with the government, we're speaking on health. It's like speaking to Revenue Quebec. You don't want to make a mistake. These are also people requiring services in English. It's actually easier for them if they were to request translation services in many cases strategically, but they're not always aware of this situation. And there's a lot of pressure on the cultural competency, and people tend to pull away as opposed to going towards the system. And there's hesitation regarding complaints and the raising of awareness that I mentioned because people can fear reprisals and they want to continue to receive services and they're worried about rocking the boat. Next slide, please. So basically, we outlined certain recommendations. This is a summary of them. I'm going to go through them very, very quickly. So we recommended, and of course, this is a wish list. Some of these are more realistic. Some of these are difficult to expect, but we put down what we think will fix the problem. So we asked that a paper copy of the government booklet, programs and services for seniors be mailed to every Quebec resident upon their 60th birthday. There's a cost attached to that, but the benefit severely outweighs the cost of seniors having this in either French or English, depending on their profile and how they access services, in order to have that starting point about how to access services. We ask that documents and forms be available in English. We have the right to these. English-speaking community has the right to these. Unfortunately, they're not always available. We ask that bilingual staff be available and that we start interpreting the recruiting provisions, even in light of the Chart of the French Language, in a purposeful way. What we're looking to do here is get service. I mean, there have been Quebec premiers have said, when you go to the hospital, you're not going for a language test. You're going for a blood test. You're going for care. It's always been something that Quebecers have agreed upon in the past, that there shouldn't be politics. There shouldn't be language. This is health. It's fundamental. It should be exempt of the debates we'll have in other areas of society. And I think there's profound agreement for this, even in the population, the general population. We can't always take the political representatives to be actually expressing the will of the majority of people. I think a lot of people, in my personal experience, and I'm not here to testify about that, has been that when we talk about health, most people say hands off. The most important thing there is for people to get the care they need. We talked about we recommended implementing a staff recruitment program, but particularly targeted towards minorities and racialized communities, in order for there to be a confidence building. because there's a traditional gap between public services for these communities, and we asked for policy to put in place to address that. Next slide, please. Next slide, please. So we talked about subsidized transport accommodation and accompaniment for English-speaking seniors. We talked about implementing a monitoring mechanism to collect data. Data is the key. Often you'd be surprised at how many government agencies do not collect data based on the language of the user. Of course, what happens when the data is not there, the demands for increased services or funding cannot happen. That's why I mentioned the importance of complaints where they're necessary, because they serve to create some kind of data, create some kind of precedence that can be called upon. Of course, this is a very difficult one. I mean, you'll have on the other side mentioned that, you know, all citizens are equal. We shouldn't collect data on this basis. The reality of the matter is that anything that further marginalizes or removes a person from government services, there should be data collected on that in order to bridge those gaps. So we also talked about developing a policy plan connected to connect English-speaking seniors and caregivers with bilingual staff, and mandating healthcare institutions to push the recruitment of personnel that's bilingual and able to meet the demands. There's some excellent things going on also. I think that's the last slide. We can maybe jump one further ahead. Yeah, there's mandating reevaluation of organizational restructuring to assess the decrease or compromise of healthcare services. Remember, I spoke about outsourcing. We want to make sure that, and now with Santé Quebec coming, there's an increased worry that with this new centralization, autonomy being taken away from local, being pulled up more centralized, that seniors and other vulnerable communities can fall through the cracks. So one of the policies, one of the policy recommendations we make is when there's such kind of a fundamental change to the organogram or to the workings of the system, there's a policy put in place to make sure that services in English to minority communities are not compromised in the outsourcing. Things that are not falling off on the way to being outsourced. It's very important. So we asked for access programs to be accessible on CIUS websites. We asked that facilitation of the collaboration be done between the regional communities and the Department of Health, the Health Department, in order to offer language information on local platforms where seniors, like I mentioned, are likely to access it at a seniors club, at the pharmacies. Local communities know best. That's where information has to be put. If seniors cannot go get it themselves, it's got to be put where seniors are going. And of course, we encourage MSS and offered our hand for collaboration, CHSSN, other partners organizations such as Seniors Action Quebec and the QCGN. If we can contribute to creating a support system based on the resources available in the community to help bridge some of these gaps. I remember when I was a sitting MNA, there was a remarkable program. Eleni will know this group. They're called the CRIG. They're an Italian group serving Italian citizens, which had literally created a program for which they had received government funding in order to accompany seniors to their appointments, where there was potentially a linguistic barrier. And I saw it was in that particular community, my experience was that the men were more comfortable, were more likely to speak French, more confident with public authorities. It was often women who outlived their spouses, whose kids were busy, sometimes had moved away, did not have a support in order to go to their appointments. And they were finding difficulty in diagnosis, in communication. And the CRIG had created a group of volunteers who were basically accompanying seniors to their appointments. And that had a huge, huge impact. So it's something that the community can do. Not all of this depends on asking the government for money and services. Some of these things we can do as a community. So I think that's it. I think I've covered as much as I could cover in the time that we have so that we can take questions. I thank you very much for your attention. I hope it was helpful. There are no magic bullets here, but it's a way of pushing the conversation forward, keeping us talking, in order to mobilize and to advocate so we can get some positive change and make sure that our seniors are well cared for, after having contributed their lives and their taxes and their contribution to Quebec society. Now that they're vulnerable or more vulnerable, they need this help. And we have to make sure that we leave politics and language out of fundamental things such as health, which is, as Walter mentioned, a fundamental human right. Thank you very much.
Thanks, Jerry. Hi, everyone. I'm Stephen Thompson. I'm the Director of Policy and Research at the QCGN, and I'm just going to moderate the questions for today's webinar. If you do have questions, we remind you to please put them in the chat. Jerry, we have 3 to begin with. I'll start with Jerry and Walter. I'll start with the first one. What is happening to the complaints process with the amalgamation of healthcare institutions and the reduced number of complaint officers, reduction of ombudsmen, and their autonomy to investigate complaints?
I see. Okay, Lenny, for a question. Or Walter, did you want to go in as well on this one?
No, I'll let someone take this one to begin with.
Okay,
please.
Okay. I mean, look, I have to be honest. I don't have the recent numbers. The reality of the matter is that there's increasing pressure, downward pressure on the resources necessary for these complaint mechanisms to be able to function efficiently. The reality of the matter is what I fear, and what we mentioned in the report is even more important, is that people are reluctant to make complaints, and they're definitely reluctant to make complaints without proper accompaniment with someone who will advise them as to what their rights are and how to do it, and their chances of success, especially if it's someone that's, I don't want to say captive in the system, but someone who's in the system and depends on the system for care. The real thing we're seeing is a reluctance. I don't know if the most important factor is the fact that there's downward pressure on resources. I know in general that people who've had dealings with the ombudsman have said that the process is professional and that it works. The reality of the matter is that our research, and people who have other information on this are welcome to add it, but our research showed that people in the system likely to stay in are reluctant to file complaints, and that is the real big problem that we noticed.
To file a complaint, I suppose you have to know what you're complaining about. And I know that your presentation touched on this, but as a policy professional working in the community, I know about access plans, kind of. But I just checked the CIS website for the area that I live in, Montargis Est, and the access plan link is broken. So I have no idea what my rights are when I go, and I think it depends on what hospital I go to, and so if it's hard for me to figure it out, how do people know, and how can people find out what their rights are under Section 15 of the Quebec Health Act?
That's exactly it, Stephen. And we did mention it. We mentioned it on numerous occasions that the information on the websites was simply not available. And that's why information on care, even general principles that are in the booklet, that's why if you're going to mail one thing to anybody in Quebec over 60, if you're going to mail one thing to them, that's what we think the government should be mailing in the language that this person uses for communication. It's a starting point. There's resources, there's basic information, and the access plan, if, other than that, the community sector has a role to play here. I think the community sector has to create programs, ask for funding in order to help bridge this gap. Where you can, those who have caregivers who have professional knowledge or have expertise, they're very, very lucky. Most people, if they have a caregiver, it means someone who will help them out or can speak English a little bit, can speak French a little bit better than they can. But often that doesn't mean that it's a lawyer or someone who has expertise in the healthcare system. And as you're mentioning, Stephen, even for people who deal with community, it can get very, very complex. And someone who's in a vulnerable situation, they're going to ask, they're going to say, oh, we don't have anybody who speaks English. And they're going to be quiet and they're going to take their seat because they're hoping to get care and they're not hoping to rock the boat. And it's what's really unfortunate.
Yeah, just to add to that, I think one of the biggest challenges we have is to reach the people who are the decision makers, the policy makers, and the legislators themselves. That's the group that we have to address, and we have to bring arguments to. If you deal with the people who are further down in the service chain, they always have a good excuse. I mean, we don't have the resources, we can't do it, we did our best, whatever. And, we're just following the rules as we interpret them. And it just kind of goes bouncing back and forth. One of the comments I made as Seniors Action Quebec, we're trying to push the idea of healthcare being a human right. There are all kinds of things that are associated with a human right. And in Canada, healthcare is considered important, but it isn't considered a human right. If we were able to bring this notion of human right and the notion of positive legislation, positive action that would require governments to ensure that services are provided, we'd have a different kind of different dialogue, get into a different sort of dialogue. It's not a dialogue around, well, there's a problem here and there's a problem there. There's a dialogue around, there's a problem with the way we conceive provision of health and social services in general across the population. So we're suggesting that we have to bring the debate up to a higher level, a more philosophical level, a more legal level, legislative level, in order to be able to fix the problems that we have, because trying to fix them from the bottom is a very, very difficult and tiring and wearing out kind of battle. You just run out of energy, and the problem is the folks who are trying to do this are the ones who are in the most vulnerable position at the time. You're in crisis, your parent is in crisis, you're in crisis, your spouse is in crisis. That's not the time you want to fight with someone about, speak to me in English because I don't understand what you're saying. This is where I think as policy initiatives, as a community, we have to bring this discussion, this conversation up to a higher level, and then appeal to people as the ones who are supposed to provide services to our community, that these are really human rights questions. They're not, they're not a question of being able to to purchase this thing or that thing. You don't purchase this. This is something that you put in place to support the entire community.
I think that's really important what you just said, Walter. I don't think folks really understand the internal limits of the Section 15 right in Quebec. Basically you have a right to ask for service in English, and if it's in the regional access plan, then you have a right to it if the hospital or institution that you're at has the human, financial, and material resources available to provide the services. So I think most of us in Quebec have probably been to a hospital or have had loved ones go to a hospital lately in Quebec. And there's a crisis. It's not a question of being served in English, it's a question of being served. The institutions on the ground just don't have the people or the resources. So this really has to be, I think, tackled at a societal level. And I really appreciate the things that Walter said.
Absolutely. And Stephen, I think I saw a comment in the chat as well about Santé Québec and us moving towards a more centralized system. At the end of the day, the explanation for that reform is that it'll professionalize the healthcare system, put experts, put professionals there. And of course, with the limitations that are inherently in the law with respect to resources and how they impact delivery of services, you can expect professional managers to be looking at things such as efficiencies, optimization, and taking decisions at a more centralized level, as opposed to at the local level where the needs are better known and where the data is available about what services are required. So yes, there is an increasing danger that that kind of pressure, professionalizing and optimizing the healthcare system as they speak by someone that's not on the ground in the community, will endanger even some of what we have available now moving forward. So this is a time definitely to push back if ever there was one.
There's a process question, just a quick one maybe for Jerry. There's a question about how the data was collected. And if you can just talk about whether or not the data collected, or if folks that weren't just mother tongue Anglophones, but other people who spoke in other communities who tended to use English, First Nations, BIPOC populations were also targeted.
Yes, we did, because yes, we did. As I mentioned, there were 16 in-depth interviews done by professionals, and acting in the system. So users, committees, community-based organizations in various regions. Why did we go to them? We went to them because it was very difficult to find data based on use of language. Unfortunately, you get into an infernal cycle. You don't have the data, you can't mobilize. It's difficult to create the data. So what we did, we went to the groups that deal and accompany seniors, and we conducted 16 in-depth interviews and collected that data. We had a set questionnaire. Everybody was asked the same question in the same way to avoid any kind of bias. We did the best we could. On the survey side, we spoke to 633 seniors and 290 caregivers, and they weren't English speaking in the sense of historic Anglos or native English speakers. We had identified, and we had particularly asked Leger to speak to people who were most likely to use English in accessing public services, including health. And that's where we take this. These are Eleni's parents, my parents, and others with the increasing inflow of immigration into Quebec. What we found, and it was funny, the ironic part was that if these people would go to an institution in almost any part of Quebec and say, I speak this third language, translation services, they'd snap their fingers and provide translation services or interpretation. But when these people elected because they had some kind of working knowledge or a comfort in English, they were being told that they'd have to make do with the resources available at the health institution, and that they would not bring in an external translator to translate from English to French and from French to English, which was like really ironic. And you're thinking you're better off going there saying, I don't speak English, I don't speak French. They'll probably take better care of you from an interpretation standpoint because of the way they're interpreting the Minister of Health and Social Services interpretation policy. It's as ridiculous as that, unfortunately. But we did take those communities into account.
We have time for one more question. And, Jerry and Walter, both with your experience inside government, inside, senior levels of the bureaucracy, we have a question from Eleni here. How do we convince the government that is focused on the issue of promoting only the French language to provide more services and resources for English-speaking seniors?
I know, Walter, you want to take a kick at it and then I can go? I think we need to shift the conversation away from language and shift the conversation towards what you mean by health and social services. Some of the thinking that I've encountered in my work with folks in the Ministry of Education in particular is that it seems that government looks upon all their ministries in the same way. So whether you're in the Ministry of roadworks or fisheries or whatever, it's the same as being in the Ministry of Health and Social Services. And fundamentally, that's false. That's wrong. Health, social services, education are totally different kind of service that you provide to the population. And in line with what was being said earlier by Jerry, people who are experts, they, if they have a hammer, everything is a nail, right? And the same thing is happening across the board in the way they work. So you have people who are expert in managing resources, expert in managing, buildings or whatever. They're the ones who have an impact on where the resources are going to go in a conversation. And that's not enough. That's not the right place. What we need to do is start another conversation, a debate around what we mean as a society when we talk about the provision of health and social services to our population, to our citizens in general. And we can't get that conversation by fixing the things that are broken at the bottom. We have to be able to fix the whole system from the top. And that requires a whole new look at what we mean by services, because too many people have the license to make decisions about what is given to people who are in need at their discretion. And that's not right. There shouldn't be that kind of a discretionary thing. If you have a right to a service, it should not be limited by someone who says, I think that this right means this. It has to be clearly defined for them from the top down that this is what it means, and you can't play with it. Jerry?
October 5th, 2026. That's the date of the next provincial election. And I hate to sound like a former politician, but politicians are politicians. The goal of a politician often, unfortunately, is to get elected and then to get re-elected. And this government, although it's been a little bit reluctant to engage, and when it did engage, to not take into account the concerns of the English-speaking community, I think as they approach the next electoral rendezvous, and like I say, it's not that far off. The preparation is already in the works. The budget, you could tell, it was less about French than about other things that concern people, because all people are having a difficult time. I think it's a good time to remind ourselves that we can continue to engage. They will be coming back asking for your vote. If not for them to say that they're particularly coddling the English-speaking community, they want a kind of clean slate. They don't want to be pulling in ongoing issues relating to fundamental things such as healthcare. And again, I can't reiterate this more. We do see it when we speak to people, even in general polling, that we do as part of QCGN's other mandates. The community at large is in favor of equitable provision of healthcare services to the English-speaking community, to other minorities. These are the people of Quebec. So I think, we're not alone when it comes to healthcare. There are other issues in healthcare, but I think we have to continue pressing the issue and taking advantage of the electoral appointment that's on the way with the government of Quebec in order to push our questions, and with the other parties who, pretend to be in a position to, and that includes the Parti Québécois, because we can't write them off. The Parti Québécois in many ways seemed more lenient and more open and more tolerant in the provision of fundamental public services than this government on many occasions. So let's not forget, and that's what I have to say about that. Thank you very much.
Thank you, Jerry. And yeah, Walter, you wanted to add, because we're run out of time.
One last comment. The problems that English-speaking seniors face in this province with access to health and social services are not unlike what our French-speaking citizens have as well. There's a problem with services, period. It's just aggravated when it comes to English-speaking seniors. So when we talk about our needs, we always think about the needs of seniors first, and then say, okay, what does that mean for English-speaking seniors? How do we address that? But the problem that we have is not just an English-speaking seniors problem or service problem. It's the problem with health and social services, period. The way it's managed, the way it's presented, the way it's organized, just is not working for the benefit of the people who are users of these services.
Thank you so much, first of all, Jerry, for all the research and especially the recommendations. And let's hope they don't fall on deaf ears of any political party, including the Premier and the Minister of Health. Although I have my doubts, but then I'm being prejudiced here. I agree that one way to change the system is also to change the government, obviously. And you and I, being in politics, know that people have the power and they've got to use it, and they have to speak up. I can tell you, just for a second, I called my M&A when I couldn't have access to my CLSC, and he's the chair of the Health and Social Services Committee. The circumstances were such that I finally did get a call back. But here's an example that you do have to take action. Thank you, Walter, and thank you for all the work you've been doing also with the Seniors Action Committee. We are all responsible for the system. So let's hope the information that everyone received today, and I thank everyone for participating, that information you can use when you decide to speak up and stand up for the rights of the English-speaking community in Quebec. And on behalf of the QCGN, I thank you so much for joining us. And have a great day, everyone. Bonjour à tout le monde. Et bonne journée.
Have a nice weekend. Thank you. Thank you.
Bye.
Yes. Bye.